Alterations of cardiovascular function. Varicose veins occur when blood pools in veins, causing them to become distended, tortuous, and easily palpable. Trauma or gradual venous distension often triggers this condition. Risk factors include aging, female gender, family history, obesity, pregnancy, deep vein thrombosis, and previous leg injuries. Managing these risk factors can help prevent varicose vein development. Chronic venous insufficiency results from inadequate venous return over a long period, commonly due to varicose veins or valve incompetence. This condition can lead to venous stasis ulcers, which are painful and difficult to heal. Proper management of venous circulation is crucial to prevent progression and complications. This diagram illustrates the many contributors to decreased renal salt excretion, a key mechanism in the development of hypertension. At the center is a shift in the pressure-natriuresis relationship, meaning the kidneys excrete less salt at a given blood pressure. Factors leading to this include genetic predisposition, increased sympathetic nervous system activity, activation of the ROS system, especially aldosterone, and endothelial dysfunction. Additional contributors are poor dietary intake of potassium, magnesium, and calcium, along with excessive sodium intake, obesity, insulin resistance, renal inflammation, and hormonal imbalances. Collectively, these factors reduce the kidney's ability to regulate sodium balance, promoting long-term increases in blood pressure. Thrombus formation in veins can obstruct venous flow, leading to increased venous pressure. A thrombus is attached to the vessel wall, whereas a thromboembolus is a detached clot. Factors that promote thrombosis, known as Virchow's triad, include venous stasis, endothelial damage, and hypercoagulable states. Additional risks include cancer, trauma, heart failure, and immobility. Superior vena cava syndrome is a progressive occlusion of the superior vena cava, leading to venous distension in the upper extremities and head. This is considered an oncologic emergency and requires immediate medical attention. Early recognition is critical for effective treatment and to prevent complications. Arterial diseases include a wide range of conditions such as hypertension, hypotension, aneurysms, thrombus formation, embolism, peripheral vascular disease, peripheral artery disease, atherosclerosis, and coronary artery disease. Each disorder uniquely affects blood flow and tissue perfusion. Proper diagnosis and intervention are essential to prevent serious outcomes like ischemia or infarction. Hypertension is defined as a consistent elevation of systemic arterial blood pressure. It is diagnosed when systolic pressure is 130 mm Hg or higher, or diastolic pressure is 80 mm Hg or higher. Hypertension can be classified as primary or secondary. Managing blood pressure is vital to prevent organ damage and cardiovascular events. Primary hypertension, also called essential hypertension, accounts for most cases and results from genetic and environmental factors. Risk factors include family history, high sodium diets, low intake of potassium, calcium, and magnesium, tobacco and alcohol use, obesity, and glucose intolerance. Lifestyle modifications play a crucial role in management. Secondary hypertension is caused by an underlying disease process that raises vascular resistance or cardiac output. Examples include renal disease, adrenocortical tumors, adrenomedullary tumors, and certain drugs. Identifying and treating the underlying cause can sometimes reverse secondary hypertension. Complicated hypertension refers to chronic damage caused by sustained high blood pressure, leading to injury in the heart, kidneys, brain, and eyes. One major consequence is myocardial hypertrophy, where the heart muscle thickens. Early detection and aggressive management can reduce the risk of target organ damage. Hypertensive crisis is a life-threatening condition characterized by a rapid rise in blood pressure. It is defined by a systolic pressure over 180 millimeters Hg and slash or diastolic pressure over 120 millimeters Hg. Immediate medical intervention is necessary to prevent organ failure or death. Symptoms often include chest pain, headache, and confusion. Orthostatic hypotension refers to a sudden drop in both systolic and diastolic blood pressure when standing up. It happens due to the body's failure to properly compensate for gravitational changes. This condition can be acute or chronic and often leads to dizziness or fainting. Proper hydration and slow position changes can help manage symptoms. An aneurysm is a local dilation or outpouching of a vessel wall or cardiac chamber. True aneurysms involve all three layers of the vessel wall, while false aneurysms involve an extravascular hematoma. The aorta, particularly the abdominal segment, is most susceptible. Causes include atherosclerosis and hypertension, and rupture can be life-threatening. This slide highlights that aneurysms can lead to complications like thrombus formation. Risk factors for thrombus development include vessel injury, inflammation, blood flow obstruction, and pooling. A thromboembolus can travel through the bloodstream, creating additional risks for ischemia in distant organs. Early diagnosis is crucial to prevent rupture or embolization. A thrombus is a blood clot that remains attached to the vessel wall. Risk factors include endothelial injury, inflammation, and stagnant blood flow. Arterial thrombi can limit blood supply and cause serious complications like stroke or myocardial infarction. Preventing clot formation is a major focus in vascular health management. An embolism refers to a bolus of material traveling through the bloodstream, blocking vessels. This material can be a dislodged thrombus, air bubble, fat, amniotic fluid, bacteria, cancer cells, or foreign substances. Embolisms can lead to serious conditions like pulmonary embolism, stroke, or infarction depending on where they lodge. Thromboangiitis obliterans, or Buerger disease, is an autoimmune disease affecting small and medium-sized peripheral arteries. It is strongly associated with smoking and results in thrombus formation with inflammatory and immune cell infiltration. Over time, it can cause gangrene, leading to the need for amputations. Early smoking cessation is critical for prevention. Raynaud phenomenon is a condition characterized by episodic vasospasm of arteries and arterioles, most commonly in the fingers. Primary Raynaud's occurs without an identifiable cause, while secondary Raynaud's is linked to systemic diseases. Patients may notice color changes in the skin along with pain and numbness during cold exposure or stress. Secondary Raynaud phenomenon can result from diseases like collagen vascular disease, pulmonary hypertension, or hypothyroidism. It can also occur due to long-term exposure to cold environments. Changes in skin color, such as pallor, cyanosis, or redness, are typical signs. Managing the underlying condition is key to improving symptoms. Atherosclerosis is a form of arteriosclerosis marked by thickening and hardening of the arterial walls due to lipid-laden macrophage buildup. This process leads to plaque formation, which narrows blood vessels and reduces blood flow. Risk factors include diabetes, smoking, hypertension, hyperlipidemia, and autoimmune conditions. Managing these risks is crucial for prevention. The progression of atherosclerosis begins with inflammation of the endothelium, leading to cellular proliferation and macrophage migration. Low-density lipoprotein oxidation creates foam cells, resulting in fatty streaks. Over time, fibrous plaques and complicated plaques can form, severely restricting blood flow and causing tissue ischemia and necrosis. Atherosclerosis often develops silently over decades, eventually causing significant narrowing of the arteries. This restriction leads to inadequate perfusion of tissues, resulting in ischemia or tissue death. Early detection and lifestyle modification can halt or reverse some of the disease's progression before serious events like heart attacks occur. Peripheral arterial disease results from atherosclerosis in arteries that supply the limbs. It commonly leads to intermittent claudication, causing pain during activity that resolves with rest. Without intervention, it can progress to critical limb ischemia. Lifestyle changes and medications are important to improve circulation and prevent complications. Coronary artery disease includes any condition that narrows or blocks the coronary arteries, leading to reduced blood flow to the heart muscle. Atherosclerosis is the most common cause. Coronary artery disease is the leading cause of death in the United States. Early diagnosis and risk factor management are key to preventing myocardial infarction. Risk factors for coronary artery disease are categorized as modifiable and non-modifiable. Non-modifiable risks include age, family history, and gender, especially after menopause in women. Modifiable risks include hypertension, dyslipidemia, smoking, diabetes, obesity, and an atherogenic diet. Targeting these modifiable factors can drastically reduce disease progression. Non-traditional risk factors are emerging as additional threats to coronary health. These include markers like high-sensitivity C-reactive protein and troponin I, as well as conditions such as chronic kidney disease and air pollution exposure. Even the gut microbiome may play a role in vascular health. Awareness of these factors expands prevention strategies. Transient myocardial ischemia occurs when coronary blood supply is temporarily reduced. This can manifest as stable angina, prinzmetal angina, silent ischemia, or stress-induced ischemia. Understanding these subtypes helps in recognizing patients at risk before full infarction occurs. Prompt treatment during early stages can prevent progression to myocardial infarction. Acute coronary syndromes represent more serious complications of coronary artery disease. Unstable angina is an early warning sign of impending infarction, where ischemia is reversible but critical. If ischemia persists, it can progress to a myocardial infarction, causing irreversible damage. Recognizing and treating unstable angina quickly is vital to prevent heart attack. The myocardial infarction occurs when blood flow is obstructed long enough to cause permanent heart muscle damage. Infarctions can be classified as STEMI or non-STEMI, and as subendocardial or transmural depending on the extent of tissue damage. Structural changes like myocardial stunning, hibernating myocardium, and remodeling follow the infarction, affecting heart function long-term. Common signs of myocardial infarction include sudden, severe chest pain that may radiate to the arm, jaw, or back. Other symptoms can include nausea, vomiting, sweating, and difficulty breathing. Complications of myocardial infarction can be fatal and include arrhythmias, heart failure, and sudden cardiac arrest. Rapid medical attention is essential. This slide presents visual histological changes associated with myocardial infarction. Damage to the myocardium begins within minutes of obstruction and evolves over several hours. Prompt reperfusion therapy can limit the extent of injury. Recognizing these cellular changes is important in pathology and post-mortem diagnosis. Continued after infarction, the heart undergoes inflammation, scar tissue formation, and remodeling. These changes can permanently alter cardiac function, leading to heart failure or aneurysm formation. Rehabilitation and medical management focus on limiting further damage and improving quality of life for patients post-infarction. Disorders affecting the pericardium include acute pericarditis, pericardial effusion, cardiac tamponade, and constrictive pericarditis. Each disorder disrupts the normal protective and lubricative function of the pericardium. Symptoms often include chest pain, pericardial friction rubs, and signs of decreased cardiac output. Early diagnosis is crucial to prevent serious complications. Acute pericarditis is an inflammation of the pericardium, usually following infection, trauma, or other systemic illnesses. It causes sharp chest pain that worsens with breathing or lying flat. A pericardial friction rub is often heard on auscultation. Treatment typically includes anti-inflammatory medications and monitoring for complications like effusion or tamponade. Myocardial diseases, or cardiomyopathies, include dilated, hypertrophic, and restrictive types. Dilated cardiomyopathy leads to weakened, enlarged heart chambers, while hypertrophic cardiomyopathy thickens the heart muscle and can obstruct blood flow. Restrictive cardiomyopathy stiffens the ventricles, impairing filling. Each form affects cardiac function differently and requires tailored treatment. Dilated cardiomyopathy is characterized by an enlarged and weakened heart muscle, leading to reduced ejection fraction and heart failure. Hypertrophic cardiomyopathy often has a genetic basis and may cause sudden death, especially in young athletes. Restrictive cardiomyopathy can result from infiltrative diseases like amyloidosis. Recognizing the type guides appropriate management strategies. In dilated cardiomyopathy, the heart's ability to pump blood is significantly decreased due to dilation and impaired contraction of the ventricles. Common causes include genetic mutations, infections, and alcohol abuse. Symptoms include fatigue, shortness of breath, and swelling in the legs. Treatment focuses on managing symptoms and preventing progression to end-stage heart failure. The endocardium can be affected by a range of disorders, including valvular dysfunction, acute rheumatic fever, and infective endocarditis. These conditions disrupt normal valve function and increase the risk of heart failure. Early detection and treatment are essential to preserve cardiac output and prevent systemic complications. Each disorder often requires a different therapeutic approach. Valvular dysfunction occurs when heart valves fail to open or close properly. Stenosis refers to the narrowing of a valve opening, such as in aortic or mitral stenosis. Regurgitation happens when valves fail to close tightly, allowing blood to flow backward, as seen in aortic, mitral, and tricuspid regurgitation. Both types can severely impair heart efficiency. Mitral valve prolapse syndrome occurs when one or both cusps of the mitral valve bulge upward into the left atrium during systole. Some patients remain asymptomatic, while others experience chest pain, palpitations, or fatigue. If significant regurgitation develops, it can lead to heart enlargement and heart failure. Regular monitoring is important for managing progression. Mitral valve prolapse occurs when one or both valve cusps bulge, or billow, upward into the left atrium during systole. If the valve doesn't close properly, it can result in mitral regurgitation, where blood leaks back into the atrium. Many patients have no symptoms, while others may report vague discomfort, such as palpitations, dizziness, or chest tightness. Regular monitoring and echocardiography are often used to assess severity. Rheumatic fever is a systemic inflammatory disease caused by an abnormal immune response to a group beta hemolytic streptococcal infection. It can cause inflammation in the joints, skin, nervous system, and heart. If left untreated, rheumatic fever may lead to permanent heart damage, known as rheumatic heart disease. Early antibiotic treatment is crucial to prevent complications. Common manifestations of rheumatic fever include fever, joint pain, abdominal pain, tachycardia, and epistaxis. Major clinical signs include carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. Recognizing these signs early allows for timely intervention and reduces the risk of long-term cardiac damage. Infective endocarditis is an infection of the heart's endocardial surface, most commonly caused by bacteria, but sometimes viruses, fungi, or parasites. It typically begins with damage to the endocardium, followed by microorganism adherence and growth of vegetations. Vegetations can impair valve function and may embolize, causing systemic infection and infarctions. Classic findings in infective endocarditis include fever and a new or changing heart murmur. Petechial lesions can appear on the skin, conjunctiva, and oral mucosa. Other physical signs include Osler nodes and Janeway lesions. If left untreated, endocarditis can lead to heart failure, stroke, and systemic embolization. Heart failure occurs when the heart is unable to generate enough cardiac output to meet the body's needs. It results in inadequate tissue perfusion and elevated pressures within the heart chambers. Symptoms include shortness of breath, fatigue, and fluid retention. Management focuses on improving cardiac output and relieving congestion. Systolic heart failure is defined by an ejection fraction of less than 40%, meaning the heart cannot pump effectively. Factors such as reduced contractility, increased preload, and increased afterload worsen the condition. Symptoms include dyspnea, orthopnea, fatigue, and pulmonary congestion. Systolic failure requires aggressive management to prevent progression and improve survival. This continuation highlights the worsening cycle of systolic heart failure. As cardiac output declines, the body activates compensatory mechanisms that eventually worsen the heart's workload. Pulmonary edema, hypotension, and the presence of an S3 gallop on auscultation are key clinical signs. Prompt diagnosis and treatment are crucial for improving patient outcomes. Diastolic heart failure occurs when the left ventricle becomes stiff and fails to relax properly during diastole. Although the ejection fraction may appear normal, the ventricle's impaired filling leads to pulmonary congestion. Causes include myocardial hypertrophy from chronic hypertension and ischemic remodeling. Symptoms include fatigue, dyspnea on exertion, and pulmonary edema. Right heart failure is the inability of the right ventricle to pump effectively into the pulmonary circulation. It often results from left heart failure, where back pressure builds into the lungs and overburdens the right side. Another common cause is diffuse hypoxic pulmonary disease. Symptoms include peripheral edema, ascites, and jugular vein distension. Right heart failure leads to systemic venous congestion and impaired return of blood to the heart. Patients often present with hepatomegaly, weight gain, and fluid retention in the legs and abdomen. Management focuses on reducing pulmonary pressures and improving right ventricular function. Identifying the underlying cause is critical for effective treatment. High-output heart failure occurs when the heart cannot meet the body's needs despite normal or elevated cardiac output. This form of failure is usually caused by conditions that increase metabolic demand or reduce systemic vascular resistance. Examples include anemia, hypothyroidism, septicemia, and beriberi. Treatment targets the underlying condition rather than the heart itself. In high-output failure, even a well-functioning heart becomes insufficient due to the body's excessive demand for oxygen and nutrients. Patients may experience fatigue, shortness of breath, and low blood pressure. Unlike classic heart failure, the focus here is not on pump dysfunction, but on correcting the metabolic or vascular imbalance. Shock is a critical condition where the cardiovascular system fails to supply adequate blood to tissues. This leads to impaired oxygen and glucose use at the cellular level. Symptoms vary by type but commonly include hypotension, rapid breathing, confusion, and cold extremities. Shock is a medical emergency requiring immediate intervention to restore perfusion. Shock can be classified into 5 main categories based on the underlying cause. Cardiogenic shock results from heart failure and impaired pumping ability. Hypovolemic shock is due to significant loss of fluid or blood. Neurogenic shock stems from nervous system damage affecting vascular tone. Anaphylactic shock is triggered by severe allergic reactions, while septic shock is caused by overwhelming infection. Each type requires specific and urgent intervention to restore tissue perfusion. Cardiogenic shock is caused by the heart's inability to pump blood effectively, leading to reduced cardiac output and tissue perfusion. Despite adequate blood volume, the heart fails to meet circulatory demands. This type of shock often follows a severe myocardial infarction. It requires immediate treatment to support circulation and cardiac function. Hypovolemic shock results from a significant loss of blood or fluids, reducing venous return and cardiac output. Common causes include trauma, internal bleeding, or dehydration. It typically develops when intravascular volume drops by 15% or more. Treatment involves rapid fluid replacement and stopping the source of fluid loss. Neurogenic shock arises from disruption of the autonomic nervous system, often after spinal cord injury or severe trauma. This leads to widespread vasodilation, bradycardia, and hypotension. Blood pools in the peripheral circulation, reducing preload and cardiac output. Prompt stabilization and vasopressor support are essential. Anaphylactic shock is a severe, life-threatening allergic reaction caused by exposure to an allergen. It triggers widespread vasodilation, increased vascular permeability, and airway constriction. Symptoms include swelling, hives, shortness of breath, hypotension, and sometimes loss of consciousness. Immediate administration of epinephrine is critical to reverse the reaction and stabilize the patient. Septic shock results from a systemic infection that triggers a powerful inflammatory response. It leads to widespread vasodilation, low blood pressure, and impaired tissue perfusion. Key symptoms include fever, rapid breathing, confusion, and hypotension. Early identification and aggressive antibiotic therapy combined with fluid resuscitation are essential for survival. MODS is a progressive failure of 2 or more organ systems, often triggered by an uncontrolled inflammatory response. The most common causes include sepsis and septic shock, but it may also result from trauma, burns, pancreatitis, or major surgery. Once MODS develops, it significantly increases the risk of death. Early recognition and aggressive treatment are essential. MODS often begins with generalized inflammation and symptoms such as fever, rapid heart rate, shortness of breath, and altered mental status. As it progresses, organ-specific signs appear, including acute respiratory distress syndrome (ARDS), kidney failure, liver dysfunction, and gastrointestinal bleeding. The hypermetabolic state worsens organ demand, creating a vicious cycle of decline. As MODS advances, clinical signs from each affected system become evident. Respiratory failure, decreased urine output, cardiovascular instability, and neurological changes may all develop simultaneously. Supportive care in an intensive care setting becomes necessary. Prevention and early control of the initial insult, such as infection, are key to improving outcomes.